5.6, the closed session minutes were approved on a 5-0 vote, and the medical staff credentialing was also approved on a 5-0 vote. And that concludes my report.
Thank you so much. Are there any deletions, corrections to the posted agenda? If there are none, then we're going to move on to audience input. And this is an opportunity for members of our audience to make comments on anything not on the agenda. If you are interested in giving any kind of comment during the audience input, if you could either raise your hand or use the icon on the Zoom screen, we will call you and recognize you for your ability to present to the board. We do limit the time to 3 minutes to do your presentation. And I apologize ahead of time if I have to end your presentation. Also, we are allowing audience to do written input to the board, and that has to come 24 hours prior to the meeting, so we have the ability to review it. So with that guidelines, I see that we have some audience. Do I have anybody that wants to speak? I see Janet Atkinson. Janet, if you'll unmute yourself, you have 3 minutes.
Thank you. My name is Janet Atkinson. I'm a 10-year resident of Tahoe, Truckee, and I'd like to talk about the health effects that I'm concerned about regarding climate change. We know that physical health is affected, and especially our most vulnerable populations, which are the young people or children and the elderly. And I happen to work as an educator with children of all ages, and I've really heard their concerns. In addition to that, I attended the forum that was put on by Citizens Climate Lobby on December 7th. It was Our Climate is Our Health. And the young people there were surprised to kind of draw the connection between mental health and climate change. The young people that I've talked to are just concerned about their future, of course. And it's very depressing, and there's a lot of depression and anxiety amongst our young populations. So really, I'm hoping that the Tahoe Forest Hospital can lead by example in showing that they are taking action as a major community player, both as an employer and as just a leader in our community and serving so many of our young people, and that you can show that you are making plans to mitigate climate change, as well as starting to work more with the town of Truckee and their climate actions. And also, there are many health organizations that work on climate action plans and serving their communities better in light of this important health crisis that is climate change. So that is why I want to speak today, and thank you for giving me the time to do so.
Thank you so much, Ms. Anderson, for your input. And again, we are very sensitive to what is happening with our young people. We are very sensitive to the behavioral health issues, and you will hear in our report at a later date what the hospital and health system is doing to help with these problems. So thank you again. Deirdre Henderson has her hand up. Deirdre, if you'll unmute yourself, you have the floor.
Thank you. Good evening. I'm Deirdre Henderson. I'm a Truckee resident, a Tahoe Forest patient, and I am the group leader of the North Tahoe chapter of Citizens Climate Lobby. It's good to see you all again. I viewed the video of your December 15th board meeting, and I was very pleased to hear your response to the community comments on climate change at the November board meeting. You said that you've asked staff to report to you on the activities, process, and planning related to climate stewardship and public health. We, of course, hope this will be done with reference to best practices and benchmarking. And we think this is an important step because the report can serve as a baseline for a formal climate action plan for the healthcare district, which we really hope you will pursue with input from the community. This is an especially auspicious time to do this kind of planning because there is very significant funding available for clean energy and building decarbonization efforts through the Inflation Reduction Act. By way of example, one of the important provisions in the IRA for Tahoe Forest is called direct pay. It enables non-tax-paying entities like Tahoe Forest to monetize the value of investment tax credits and production tax credits for clean energy projects, either by receiving payment from the federal government in the amount of those credits or selling those credits to other entities that can use them. So you're now eligible for those important incentives. That has never been possible before. You also mentioned in December that you have partnerships in connection with climate stewardship. However, as of the meeting on January 13th of our community's Climate Transformation Alliance, that is one partnership that you have not joined and have not attended any meetings of. And we urge you to join the Climate Transformation Alliance because it offers important information on implementing the system transformation that we need to address climate change. And it's a vehicle for collaboration on climate action with other community entities. So thank you. And we look forward to reading your staff's report. And we hope to working with you on next steps. Thank you very much.
Thank you, Deirdre, for speaking. And again, I want to remind you as a district, we are covered by certain regulations. And when we do our presentation on what the hospital is doing as a steward of our environment, you'll hear some of the limitations as well as some of the actions that we have been able to take in order to decrease our carbon footprint. And I look forward to having that report done next month. Again, we're in the midst of a lot of accreditation surveys, and that's where our priorities have been over the past 2 months. So you will be hearing from us on our stewardship. Any other comments?
Very much looking forward to it.
Okay. Any other comments from our audience? If no other hands are raised, then we'll move on to input from our Employees Association. Do we have anybody from the employees? Okay, nothing from our employees. So we'll move on to item 12, and this is acknowledgements. It's the fourth quarter 2022 value recognition. And every quarter, the health system recognizes employees who demonstrate the values, and especially a particular value in their day-to-day workings. And I have the good fortune to be able to announce who they are. These individuals were invited to a service award dinner, I think it was last week, at which they received their award. So for quality, and if you remember, our values spell out the word quest. So our quality value went to Adam Whitman, and he is in IT. Our understanding went to Morgan Gray Braunschneider, and he or she is in nursing administration. Our excellence award went to Hillary Conkling, and she is in the pharmacy. Stewardship award went to Tim Coates, and he is in the facility department. Jennifer Santoris received the teamwork, and she is in IT. And we did have some recognition for Dr. Melissa Kame as our physician, who demonstrates the values of our organization, and also to Kat Sigafus, who is in patient access. So congratulations to these, and we look forward to having you share your example to the rest of our employees. So a hand for all of those. We'll move on now to item 13, the Medical Staff Executive Committee meeting consent agenda, and that is Dr. Koch. So Dr. Koch, if you'll unmute yourself, and we'll have our fingers crossed that your audio works.
How is that?
You echo. So one of them needs to be turned off.
This should work fine as long as my Wi-Fi holds. If it doesn't, I had both going so that if my Wi-Fi craps out again, I can jump into my iPhone, which is just a much smaller screen, but if I need to, I will. And so Dorothy will start sharing her screen so that we can have the agenda up.
Sorry, Martina, are you able to? Oh, there, I can share. There we are.
All right.
Joy, excuse me for just a second. This is Dale Chamblin. Could I just say one thing before you make your report? As you probably know, 4 of the 5 of us on this hospital board do not have a medical background. Nevertheless, we're charged with the responsibility for approving all hospital policies. And I personally believe that in order to responsibly discharge my fiduciary responsibility, I have to rely on the advice of those who are medically trained for their advice. And I find it helpful when presented with policy changes. If you can also briefly let us know the reason for the policy change or the policy itself and who wrote it and whether it meets the standard of the industry so that I can rest assured and the other board members who are not so medically inclined can also rest assured that they're voting properly to accept. Does that make sense?
That makes all the sense in the world. That's excellent reflection, and I will work to complete that.
Okay, thank you.
Yes. So first group of policies is the annual policy review for nursing, surgical, emergency, and propofol. These are all policies that are in existence. There are no changes to them at all. They are being approved each year, which is a requirement, but without any changes from previous years. Would you like to see any of these policies?
Sure. Can we see just one of them?
Yeah, let's go ahead and put up the nursing services policy.
Okay. So are you going to be able to open one of those, or is that just the table of contents?
I think Dorothy's working on opening one of them. We were looking at one of them earlier today.
Yeah, these are the table of contents. There were no changes to these list of policies. They were just an annual review, which is required as a critical access hospital. I can pull the propofol one to give you an example of the policy.
Well, I appreciate that because that one does have the risk statement on it. And I think I brought this before the board at a committee, at a meeting before, is that we're not being consistent about the risk statement, and that we see on the policies that you show us that there is a risk or not a risk, and we'll make a comment. But when we see only the content, the table of contents, then we're trusting that there is a risk statement. And I understand that's not a credentialing requirement, but it is a requirement put forth by the high reliability committee. So again, I just want to bring that again to everybody's attention, that are we going to be consistent in having a risk statement? And the risk really is to the risk to the health system, to the patient, to the employee.
Thank you, Alice. I was actually at the meeting when you pointed out that we were missing that risk statement, and that we had instead a policy statement, but without the risk assessment at the start of it. And so this group of policies that I'm reflecting on now are all already have that risk statement in them, and the next group on the list are the ones that we added that to.
Okay, so the nursing, surgical services, emergency department, all have them.
All have the risk statement already. That's correct.
Okay.
And the policies with changes that are the anesthesia and proctoring policies are the ones that were missing the risk statement in November and are being brought back with the risk statement included.
Thank you for doing that.
Yeah, well, thank you for pointing it out. We do want to be consistent, and that was an oversight. There's a new privilege form, and this form was created based on what's called a white paper, which is a nationally recognized standard that describes privileges. And in this case, it's for physiatry, also known as physical medicine and rehabilitation, which is the specialty for providers who focus on procedures that help with pain management, like epidurals and facet injections and nerve blocks. And so we have Dr. Allison Ganong, who will be getting this credentialing, and she has reviewed the form in addition to us having followed the white paper guidelines, and she has approved this form as well. And it follows the basic format of our other credentialing policies, in that it requires board certification or board eligibility. It requires good standing in the medical staff, et cetera, et cetera. So I'm happy to open that one up if you'd like to.
Doesn't look like anybody is in.
Okay.
Yep.
All right. Then next, I'd like to introduce this is just for information, the new medical staff leadership that was elected at the end of last year and started on January 1. I am the chief of staff now, and Dr. Erin Capel, our oncologist, is the vice chief of staff. Immediate past chief, you know well, Jonathan Lane, and the secretary treasurer remains Jeannie Plum, and the member at large remains Michelle Kim. In terms of the departments, Dr. Tennille Bainey remains the chair of anesthesia, and Dr. Justin Ward is the vice chair. For emergency services, Dr. Aaron Gladman is the chair, and Dr. Chris Scapp is the vice chair. For medicine, Joshua Fent remains the chair, and David Ritchie remains the vice chair. For OB Pediatrics, Dr. Chelsea Wicks is the chair, and Dr. Sarah Fletcher is the vice chair. And then for surgery, it's Dr. Justin Hunt with Dr. Jonathan Hagan as the vice chair. And in incline, it remains Dr. Abby Young and Dr. Michelle Kim. And then our quality chair, which transitioned last year, will remain for the foreseeable future, Dr. Anamika Conway, ophthalmologist.
And again, that was just for informational purposes.
Yes, it's just information.
Officers.
Yeah.
So are there any questions from our board regarding the policies and, or what are they called? Privilege cards that have been presented? Okay, anything from our staff? Any comments from our audience? Okay, well, this is going to make it easy. We'll ask the board for a motion to accept the medical staff meeting consent agenda as presented.
Mr. Director Barnett, I will so move.
Dale, I'll second.
Okay, so it's been moved by Director Barnett, second by Director Shamlin, that we accept the medical staff meeting consent agenda as presented. Could I have a vote, a roll call vote?
Director Brown?
Yes.
Director Shamblin?
Yes.
Director Barnett?
Yes.
Director McGeary?
Yes.
and Director Wong.
Yes. So Dr. Koch, the agenda has been approved.
Thank you very much.
We'll see you next month, if not sooner. We'll move on to item 14, and this is the consent calendar. These are usually non-controversial reports, policies, and resolutions. And the board has the opportunity to pull anything that they want to further question. So from our board, is there anything that you wish to have pulled? Okay, anything from our staff that they wish to pull? Any comments from our audience? Okay, hearing and seeing nothing, I will move on. Oh, no, I'm sorry. We have to approve the consent calendar. So can I have a motion?
Yeah,
I would move approve.
Okay, Director McGarry has made the motion. Can I have a second?
I'll second the motion.
Okay, so it's been moved and seconded to approve the consent calendar as presented. Can I have a roll call vote?
Director Brown,
Yes.
Director Shamblin,
Yes.
Director Barnett,
yes.
Director McGarry,
Yes.
Director Wong.
Yes. So the consent calendar has been approved. Moving on to item 15, and this is again a board action item, is our compliance report, or I'm sorry, our 2023 corporate compliance work plan. And we have Garrett Smith from the Fox Group who will present that.
Hello and good evening, and thank you for the opportunity to walk the board through the work plan. We'd like to get your approval for it. Just to note that this is based off of the OIG guidance of 7 components of a compliance program. So a couple of highlights I'd like to bring our attention to are the auditing and monitoring section. There are 14 planned audits that the compliance committee feels that represents a good risk benefit analysis to completing internally in the upcoming year. And scrolling up to the high level oversight, and that's something that is new, would be the board evaluation of corporate compliance program. This is scheduled for the 4th quarter, and we would like to solicit the board's input on the evaluation of the compliance program. A lot of hospitals have found success in submitting surveys and getting feedback and input from the board on the compliance program by soliciting the board's feedback. So the compliance committee will draft something, and the best way to get this feedback, but that is something I wanted to point out. And the rest of the items are kind of process and policies already put in place to respond to detective offenses and in a timely manner and report things. So nothing really much to bring the board's attention to in the rest of these items.
Garrett, excuse me, this is Mary. I'm curious, what is the break the glass report?
Oh, that is an item in which within the medical record, a provider, nurse or physician, if someone's labeled as a VIP or something like that, the feature is called break the glass, in that the provider or whoever's in the medical record has to enter in an affirming statement that, yes, I have a valid reason to access this person's medical record. I am providing care in a certain way. So it's usually a very quick statement that the record will pop up and say, hey, this access is restricted. Do you intend to really come in here, and do you have a valid reason? And that would just prompt the user to verify that, yes, I do have a valid reason, and type in whatever reason that they want to get into this patient's particular record.
Okay. Thank you. The others are pretty self-explanatory, but that one baffled me.
Yeah, that one's a HIPAA privacy type of one.
Any other comments from our board? Anything from our staff? Again, these will be the audits that will be monitored during the year, and we'll be getting regular reports from Garrett Smith on the achieving of it. Any comments from our audience? Again, this is an action item, so we will need to have a motion.
Yeah, quick question, Alice. Is the expectation that this will remain the same year over year, or will the plan itself be reviewed as well?
Garrett, you want to answer that? What it sounded like to me was it was going to have input every year.
Yes, this is an annual work plan that we present to the board annually. I would say the changes to it are more evolutionary. So these risk areas, these headers kind of stay the same, but as the risk profile changes, these audits will be updated or taken away as needed. But some of these will stay, pretty indefinitely where, yes, we need to submit to HHS an annual report of any unauthorized HIPAA disclosures. That for sure will stay static. A lot of these are static, but I'd say, at any given time, maybe 20% might be in flux from year to year.
Okay, thank you.
It would depend really on what the national standard best practice white papers put out as areas that need to be monitored.
Yes, excellent point. Yes.
Okay. So I'm sorry, I got distracted. Did we vote on it?
Not yet.
Not yet.
Yeah.
Thank you. Then we'll move on to item 16. And thank you, Garrett, again.
Thank you.
Item 16 is just for discussion. And we have...
We will need a motion, I believe, on item 15.1.
Oh, I thought that's why I just asked.
Yeah,
Okay.
we had not voted on it.
Okay, so we have a motion.
Yep.
And now we need to vote on it.
Yes.
Who made the
Okay.
motion?
Well, the motion was not made yet.
No, we haven't.
Director McGarry started asking questions before a motion.
Oh, that's right. That's right.
But I will move to approve.
Oh,
Yeah.
yay.
Compliance work plan.
A second. Can I have a second?
This is Director Barnett. I will second
Okay,
approval.
so we have a motion to approve the work plan for 2023 for corporate compliance. Now we need a...
Director Brown.
Yes.
Director Shamblin.
Yes.
Director Barnett.
Yes.
Director McGarry.
Yes.
Director Wong.
Yes. So we have approved the work plan now. And then we'll move on to item 16, which is the fiscal year 2023 to 2025 strategic plan update. And I think, Louis, you're going to lead the discussion, our Chief Operations Officer.
Yes, Director Wong. I'm going to have a little bit of help along the way, but I will lead. First up, Martina, am I sharing or are you sharing? There we go. Told you I need a lot of help. So,
You and me both.
yeah. Well, evening, Director Wong and fellow board members. I am here to talk a little bit about the fiscal year 2023 through 2025 strategic plan and just give you a very high level update of activities that have been occurring here at the health system. Before jumping into what we've actually been working on, I do want to just recall everyone's memory back to this document, which is a one-page, very quick to consume document that really dives just kind of surface level of what we're actually looking to achieve between the years of 2023 and the end of our fiscal year in 2025. So if you just take a look at the document, if you look at the strategic priorities in the row going from left to right, our objective is to deliver outstanding patient and family experience, provide excellent patient-focused quality care, strengthen a highly engaged culture that inspires teamwork and joy, ensures strong operational and financial performance for long-term sustainability, and expand and foster community and regional relationships. And below that, you'll see a list of objectives. Those objectives also are very high level. Just an example of that would be continuously improve access to care, right? So clearly there is a lot of work that needs to occur to continuously improve access to care. And so we even go one level lower, and that would be called tactics. And those tactics are kind of more bite-sized, meaningful approach to kind of rolls up into that continuously improving access to care. So that's a document that we work on internally here at the health system, and can add to and subtract from as we go along through these next few years. So just moving to the next slide, we have to find a way to measure our work here. And what you have here in front of you is often referred to as a stoplight report. And just before diving into this report, I just want to call your attention to the performance key. So if you look at the performance key, you'll see that anything in green is a goal complete, anything in yellow would be a goal on timeline, and anything in red would be a goal delayed or a significant barrier. It is absolutely reasonable at this point, 6 months into our strategic plan that was adopted by this board in February and went into effect in July, that most of our current metrics would be in yellow. So something that's on timeline, something we're working towards. We do in fact have a few greens here, as we'll get into here in just a minute, but absolutely nothing in red at this point, which is also very likely with 6 months into a project plan or a strategic plan, as we have not ran into significant barriers at this point, or at least that would stop us from completing a goal by the end of the fiscal year 2025. So this is not meant to be fully comprehensive of every goal that we're working on here at the health system. It's really a dashboard for us to look at as an administrative council and decide whether or not to increase or subtract from this metrics document. As you notice, we do have some in green just 6 months in. We may want to focus our attention and really kind of up that goal. Likely you will continue to see those that are in green stick around because they are very meaningful goals in terms of quality. But it does give us an opportunity to add to and potentially just elaborate on these metrics. So we'll be meeting often quarterly to discuss where we're at in these metrics and add to as need be. We also intend to review and revise metrics document in an upcoming board retreat. So we'll kind of dive a little deeper into this document then as well. But at this point, I'm going to pass it over to a few of my colleagues who are prepared to make some comments about each of these areas that we have highlighted here. So Scott Baker is on with us, and he's going to talk about our metrics that fall under outstanding patient and family experience, and talk about how that's going to improve or continuously improve access to care.
Yeah, thanks, Louis. Good evening, board. I'll touch very quickly on the metrics that you see in front of you. We've put those in place as initial targets for the different fiscal years that are part of this 3-year strategic plan. Right now, our MSC overall satisfaction is hovering around 50th percentile, depending on the comparable and depending on the quarter that you look at. So our goal is to get that up above 60th percentile by the end of next fiscal year and above 75th percentile by the end of this strategic plan period. With several projects already underway to address those areas with the most opportunity to improve. And then next on the metric list are very important access measures. We generally use third next available appointment. That's a very generic measure, all-encompassing measure in all of our areas, and we've designated those in both primary care and specialty. I can tell you that we're already 2/3 meeting our goal in the specialty areas, which is pretty uncommon, especially given our limited roster of physicians, but we've already made some great progress there. Primary care, a lot of work has gone into primary care over the last 6 months. I can tell you, for example, I just did the calculation that this past December that we just went through, had 20% more primary care, urgent care appointments than last December. So we're already seeing a lot of progress there. Not quite meeting our goals there yet, but we're well underway for this 3-year period. And then the lean principles, we've already done several projects introducing lean principles to the management team and the directors. We'll continue to involve more and more lean projects in this project over the next 3-year period.
All right. Thank you very much, Scott. And we've got Dr. Evans here to talk about our excellent patient-focused quality care. And I think I'll help him out a little bit towards the bottom of that in terms of nursing home.
Yeah, thanks, Louis. Good evening, board. So we are on sort of column number 2. We're looking at the hospital compare quality 4-star and then 5-star. So as you know, we are a CMS 2-star currently, and the goal is to get to 4-star, then 5-star, and be there sustainably over time. I think that most of you are aware there are numerous metrics that go into this assessment that is done by CMS. There's about 24 individual metrics that are relevant to Tahoe Forest, and we do very well on most of them. There are several where we are not at goal, and usually it's just a handful of patients that take us off of goal. So I've been working very closely with our Director of Quality, Janet Van Gelder, and many others to make sure that we are really shifting our focus to look at concurrent opportunities to hit the metric for every single patient we see every day. So rather than look at these metrics retrospectively, we need to have essentially a checklist that we are reviewing on all the pertinent measures that go into high quality care and safety. And so we're building a dashboard that allows us to do just that. And we're creating essentially, if any of you are familiar with being an airline pilot, you have a checklist of things that you have to do before you're cleared for takeoff. And we have to do that on an ongoing basis on every single patient that we care for at Tahoe Forest. And so that's essentially the goal. It's a huge amount of work because, as you can imagine, the checklist involved for just one of the metrics is quite lengthy. When you talk about falls, or if you talk about C. diff, or you talk about many other things. So we are currently in the process of building that, and I'm confident that we'll be able to improve our performance on that. So those are the two hospital compare quality, the CMS 5-star ratings that we're talking about on those two. The next one is on HCAHPS, and I'm not sure how many of you remember what that acronym stands for, but this is essentially a patient survey that is provided to patients who have been discharged from the hospital and then go home. So this does not include nursing home patients, but it includes anyone who's discharged and goes home. And they're asked numerous questions about the care that was provided to them. We do extremely well on this historically at Tahoe Forest, and there's a lot of reasons for that. It does reflect the culture that we have, the community that supports us, and a legacy of really outstanding care at Tahoe Forest. We do treat family members as part of the overall care team, and I think that's very important. We're very focused on introductions, explaining the care that's provided, talking about the duration that people are going to experience, and we thank people for the opportunity to take care of them. We're focusing specifically on things like noise by using white noise machines and having quiet zones, and every employee goes through perfect care experience training, which I think is really valuable. We also have warm handoffs, and we have a really good service recovery program as well when we do need to use that. So a lot to be proud of on the HCAHPS score, and we're already at goal complete there. But now we just need to sustain that for the long term.
Thank you, Dr. Evans. Actually, much of what Dr. Evans just explained could also fit into the next two boxes in terms of nursing home compare. As you notice, we have met goal on nursing home compare, which is a CMS standard that allows us to continue to work towards a 4-star and 5-star in our nursing home. we are delighted here that we are already a 5-star, and the work that the staff does with the residents, really reflects a 5-star facility. So now it's our job to maintain it, and that is just as hard as achieving it, maybe even harder, considering we do have annual surveys. There is considerable resources by the California Department of Public Health that are working with our staff and always here within the facility. In my year here at the facility, they've been here 4 or 5 times, and they're always working to make sure that we're providing the highest of levels of care. And so I'm very confident in Maggie Link and her team within our ECC. And I think if we continue to keep the efforts and just a real sense of pride that we deliver great care to our residents here, that we will continue to maintain this goal. So this is something we watch very, very closely with a number of staff here at the health system. And we plan to kind of continue to keep working through this and adding to it to make sure that our residents here always feel like this is home. So moving on to our third objective,
Louis, excuse me. I'm sorry. I was on mute there for a minute. I have a question about the nursing home. First of all, that's just wonderful news. That is just great. But I'm a little confused as to whether or not we have hit those metrics that will entitle us to the 5-star rating, or we've already been rated 5-star. Has it been acknowledged that we're a 5-star?
Yes. So we are a 5-star facility.
Wow. That's great.
Yeah.
And I'm really happy that we're starting to look like a 5-star facility in the extended care with the remodels that's being done.
Yeah, it really is amazing the work that's been done in the ECC. And unfortunately, we haven't had visitors come in as often. I mean, it is open for visitation, but it's really wonderful to walk through there and just see the upgrades that have been made, and it truly impacts the residents in the most positive ways. So we'll just keep working towards bettering it all the time. I think even though we're 5-star and we're very proud of it, we can always do better. So we'll just keep working on it.
Louis, Dale here. Could I ask you a quick question too before we get too far down the road here? For Scott Baker, Scott, you mentioned improvements in primary care and urgent care, and all in the same sentence. I have anecdotal. This is strictly anecdotal. I get comments from friends who say I can't get an urgent care, or excuse me, I can't get a primary care physician, or I can't get a primary care appointment, and so I'm going over to urgent care as an alternative. Is there a trend there to substitute urgent care for primary care?
There is, and they definitely balance off of each other. If you have to wait too long for a primary care appointment, some issues just can't wait whatever it is at that time, 2 or 3 weeks to see your primary care provider. And in some cases, they're actually guided to urgent care if they're triaged and deemed appropriate to go to urgent care instead of wait. What we've also done is started to add more last-minute appointments to primary care to improve access in those cases. There are still some anecdotal situations where we're not meeting those standards, and we continue to work on those. Part of the reason I mentioned primary care and urgent care together is, there are several providers that do both. So if you're looking at historical numbers, it's usually best to combine those together. But we have now separated the space for primary care and urgent care in Truckee. We've hired several providers in both areas. They're just getting ramped up, so I expect the trend of more access in both urgent care and primary care to continue. And we still have ongoing recruitment in both areas.
Okay.
Could you clarify?
Dale, this is
Go ahead, Harry.
This is Harry. Just to give you a little bit of progress, just from a global scope, last fiscal year, we did approximately 116,800 clinic visits, primary and specialty care. We're on pace now at the 6-month interval to be approximately 122,000 this year. So I am pleased with I think the speed up in primary care and especially specialty care. And we urge people out there, if they are having difficult, call our office. And we've been able to, and that's one of the beauties of being a local health system. We can solve problems as we're continuing to refine processes. But I think it would be hard pressed to have any rural hospital in America that would have changed team space and the huge amount of adjoining team members that would have allowed us to go from 47,000 to 116,800 last year to 122,000 this year. And we are deeply committed to making still major improvements. So I think there's a lot of progress even just since June 30.
Thank you.
Yeah, thank you, Harry, for that additional comment. So we'll move up to strengthening a highly engaged culture that inspires teamwork and joy. And Alex McLennan, our Chief Human Resources Officer, is going to take the first box.
Thank you. Yes. Employee engagement survey is what we use to measure this. And as you know, it's not, humans and culture is not a very objective measurement. But that survey, as you know, provides us with great detail on how we're doing in this area. And so we actually did just complete an engagement survey through Press Ganey, and we're going to be reporting out to you all those results in February. I am pleased with the results. We did hit the metric so far, but it's a 3-year plan, so we'll probably do that again before we're finished. I just wanted to touch base on a couple of things that we've been doing. When we get these employee engagement surveys, we then really focus in on the detail, and we start to try to understand it at a deeper level by holding focus groups. Once we have those focus groups and feel we understand what the challenges are, we go deeper and start to build action plans. And then those action plans, as they progress, obviously start working on the metric that we've identified as an area of an opportunity. Beyond the focus groups, we continually build strong culture with our unions and our employees. We're in current contract negotiations with our unions right now for our outpatient clinic employees. We did start also, shifting gears a little bit, we started a PEAK program, which is basically like a career ladder for our nursing staff. I'm really excited about that. We've gotten about 60 people interested in participating in that. And we, as you mentioned this morning, at the start of the meeting, we started our values recognition program, which has been outstanding so far, very well received. Last quarter, there were nominated about 100 and something people that were nominated for those awards. So really strong engagement there. And then lastly, I'll mention that we are going to be sending out total reward statements. Those statements will include a lot of detail about what employees are actually receiving from Tahoe Forest beyond their paycheck, so they can really understand all the different areas that we're trying to help support employees financially. And with that, I'll pause there.
Thank you, Alex. Maybe I'll just stop and ask if anyone has any questions for Alex. And if you think of one, we do have a slide for questions. So we're going to move on to medical staff engagement. Obviously, this has been a topic that's at the top of all of our minds. So Dr. Evans, our new Chief Medical Officer, is here to speak about some of the activities that we've done in terms of medical staff engagement.
Yeah, thanks, Louis. So Press Ganey does this survey as well. So they alternate years. So they'll survey the employees, the non-medical staff employees, 1 year, and then the next year they'll do everybody else. So the last time we surveyed the medical staff was about 14 months ago, and so that was at the end of 2021. And at that point in time, the physician engagement score fell right on the 52nd percentile, so not where we want to be at goal, sort of right in the middle of the country. And this is a national challenge everywhere. So that was actually a little bit of a drop from the 2 years prior, so back in 2019 at 64th percentile. So we have a lot going on to really bump this up. There's been a huge investment in terms of bringing in additional physician leadership in the medical director space and trying to make sure we have a mechanism to engage those leaders one of the things that I've been really making sure people understand is that we are about shared decision making and involving physician leadership in operational discussions to try to make sure they understand what the problems are and make sure we're aligned on what the solutions are. That takes time, that takes a lot of communication, but it is very effective at generating alignment and engagement for the medical staff. And I'm already seeing some positive things associated with that. We do have a partnership council now, which was originated before I started. We've had one meeting. We're going to be having many more of those. And I think that's a really good opportunity for the physician leaders to engage on significant operational matters that we're facing at Tahoe Forest. And they need to understand what we're up against as a rural hospital. We are not immune to some of the macroeconomic challenges that we're seeing across the country, and the physicians and the APPs need to be well aware of those and really be aligned with us on the solutions. So those discussions are going very well. We also do have a chief wellness officer now, Dr. Josh Kreis, who is outstanding, and he's going to be getting specific training to become essentially a certified chief wellness officer through Stanford. He got accepted to their program, so that was good news, and we're supporting him in that educational process. We have a lead APP now, and there's a lot of examples where physicians and other clinical leaders are becoming more involved in the daily work that we all have as administration. So I'm very optimistic, but this is not going to be an immediate, snap your fingers and everybody's going to score 90 percentile. But I think we can get there, and I think we'll hit the target.
Thank you, Dr. Evans. I'll just pause and see if there's any questions.
Dr. Evans, as far as our new leaders in the various specialties, are they getting some assistance or direction or education on leadership? Because many of them have always focused just on the clinical part of it, but to be engaged in being a leader and what it means when you're a leader.
Yes, they are. And in fact, I'm meeting with every single one of them. I'm also going to be meeting with them along with Scott Baker to sort of look at the service line on a quarterly basis with all of them on an ongoing pattern. Some of what you're talking about is in development, because one of the things I'm very familiar with and I've done a lot of is physician leader development. And I did that for Northern California for Common Spirit Health. So I'd like to do something along those lines at Tahoe Forest, where we invite formal physician leaders or physicians who have high leadership potential and develop them as leaders. And there's a lot of ways we can do that. We just need to customize that for our particular setting in a smaller system. We do have Dr. Steve Beeson, who's going to be coming to present to our medical staff and others about leadership and engagement. And I think that's going to be a nice way to jumpstart things. But we need to have a longer term plan. And that, like I said, that's still in development. But I think it's important, and I appreciate the question.
And the other part, too, is what we've seen in the past when they're changing leadership from year to year to year, that has not proven to be the best in terms of the department or of leadership. So, again, I don't know if that's going to be part of your plan in developing future physician leaders.
Well, I want to highlight something which is important, and not everybody fully understands this. There's a medical staff officer structure, which is a requirement because we have an independent, self-governed medical staff, and the officers do rotate quite rapidly, and typically their term is 2 years. Medical directors don't necessarily rotate over that rapid period of time. So you can have a medical director in position for many years, actually. And there's advantages and sometimes disadvantages to that. So we have the opportunity to cultivate people who have leadership ability or potential and keep them engaged. Many of you probably know physicians aren't actually trained in leadership specifically when they go to medical school and residency. They become clinicians. So there often is a little bit of a gap in their ability when they get into these leadership roles. So we can backfill that to a certain extent, and I think we need to plan a little bit more around how to do more of that.
Well, thank you for clarifying the difference between the officers and the department directors. So thank you.
All right. Thank you very much, Dr. Evans. So when we're moving across the row there, we get to ensure strong operational and financial performance for long-term sustainability. It is absolutely appropriate that all of this is in yellow, as if you look at the actual metrics, they don't come due for quite some time, fiscal year 25. Crystal is here if you had any questions, but this should look rather familiar to everyone in terms of our goals here. So any questions, any comments at all?
This is Director Barnett. I guess it's direct question to Crystal. And I've just noticed that our cash on hand, I think that's the right account, seems to be slowly moving back. In other words, our goal was 30 days, and I think we're down around 10 or something. Just would entertain comments on that.
Well, I would like to clarify that is only our operating checking account that you're referring to, that our actual days cash on hand is much higher than that. I believe it was 172 on the financial report. So we are definitely not as low, just the operating checking account. We like to keep it 30 days. And that's really highly dependent on what the balance happens to be at the end of the month. And so our overall, though, yes, our cash is improving. We're actually seeing improvement overall in our financial situation. We're progressing to get back on track for this fiscal year. We've seen increases in revenue. We've been controlling our costs well. We have been assessing our capital appetite and making sure we're managing that to keeping everything still in balance financially. So we do our 10-year forecasts, we do our budgets. Those forecasts target getting us to the goals you see before you. And I do believe by the time we hit 2025, our goals are achievable. The only metric that we may not hit, and that will be dependent on the cash investment we make in our master plan, may be days cash on hand. And that will be looked at between our balance of any new debt we might have versus choosing to use our cash reserves. So, but other than that, I do believe we'll hit our target by 2025.
Great, very helpful. Thank you.
Sure.
Louis, just a general question. I'll use this column as the example, but we're saying, in setting certain metrics for, year end 25, that's a long time away. So what about the end of 23, end of 24? How are you looking at progress towards the goal along the way?
Sure. You go ahead, Crystal.
Thanks. So even though these are targets for 2025, if we can steer and drive the organization to these metrics sooner, that will be within our forecasts and our plans. I can tell you the 60 days for AR, I hope I meet that by 2023. So within the next 6 months, I want to be at 60, maybe even 59.9, just to throw it out there. So even though they're 2025 dates, I will say internally our team is driving to hit those sooner rather than later.
Yeah, and I just one last comment. This document, when we're looking at the overall strategic plan, which of course is quite lengthy, we do have to measure it somehow against like the actual plan that was adopted by the district board. And so these are the metrics really high level and out into the future that we expect to see. However, we do have a document below objectives that are the tactics, and essentially that is the more smaller bite-sized pieces that we may be able to achieve in the next 6 months or the next 1 year. So that's a document that we keep internally, and we kind of are constantly revising that document as well. So just to add to that.
Louis, if I could just insert too a little bit, especially in this strong financial and operational, as our board reflects back on our budget for fiscal year 23 and the 10-year forecast, our capital needs don't just pop up each future year kind of with the same size and shape. Some years are really large, some years are smaller and so forth. And so that's another reason why we're not walking at a pace that just moves at a certain speed forward every year. Some years we're having to really kind of take on a big bite, and then we slow down a little bit, but we really have our eye on protecting forward progress, not allowing too much erosion, but really getting to that goal in fiscal year 25, knowing that our tough goals to serve our patients are not the same size bite of food every year, to use that metaphor.
Thank you, Harry. Crystal, do you have any other comments?
I was just going to say the ability to achieve our financial targets is also dependent on our success in our other categories. So as we look at, patient and family experience and patient satisfaction and patient access and things we're doing in that category really should help drive our ability to hit our financial metrics. So, financial metrics don't stand by itself. It's highly dependent on everything else within the strategic plan, operating and executing to eventually be able to achieve the metrics you see before you. So it's all interdependent for sure.
Well, that very well sets up our last column in terms of growth. So expanding and fostering community and regional partnerships, and metrics here are very likely to change maybe more frequently than anything towards the left of the document. As we achieve them, we will then look to replace them with other goals. So in terms of the top metric here, ophthalmology surgical services growth by 100% by fiscal year 25. We could clearly see from a past document called the Krentz data that there was a big gap in the services that we provided in terms of ophthalmology, that there was a number of patients that were seeking services outside of our district for ophthalmology. And once we knew that, Scott Baker went to work and recruited in an ophthalmologist, and that has been very successful for the health system in terms of making sure we're delivering care that's needed here close to home. So we're continuously working on this particular service line. Right now, our baseline calendar year of 2023, we're expecting to end the year with about a little over 1,600 visits in terms of ophthalmology. So that's 1,600 visits that didn't happen a couple of years ago and all went down to the Reno or Sacramento area. I'm going to skip 2 down here because I think what sets that up is selecting a software partner in an effort to gain data to decrease outmigration, which is essentially the term for when a patient does leave the area and seek services elsewhere. Sometimes that's appropriate. Maybe it's something that we cannot do here, but sometimes we really see that as an opportunity to make sure that we do invest time and effort and recruit the necessary physicians to ensure that that service here is close to home. And so one of the goals that we have is to develop and implement a plan to increase access to highlighted services from working with a partner or software and better understanding what needs to stay here in the community. What can we do to improve access to these specialty offerings that are leaving the community? So ophthalmology is a great example of what we learned in our last report. I expect that we'll learn more in future reports, and then that will likely end up as a metric as we move through this plan. And I also want to call your attention to developing infrastructure for telemedicine services. This course was very, very important in terms of our COVID response. There was a lot of telehealth that was used. In past years, it was not as easy to get patients to sit in front of a computer and access care in that way. It was not something that was comfortable, really. We've seen a very clear turnaround in that, where patients are not only comfortable, but they in fact are seeking a telehealth offering. So we want to implement telehealth offerings in primary care, pediatrics, and women's health by fiscal year end 2025. That's not a totally exhaustive list. It's just 3 areas we see that could really impact access to care in our community in terms of getting people in for quick and efficient visits. Now, I will say that we are going to have to work on financial reform with our largest payers. So telehealth is kind of utopian when you think about what it could be, people being able to access care for very routine visits in quick and easy ways. However, we do need to work with our hospital partners and state associations to really make sure that that can become a reality. So that'll be part of this goal as well. And lastly, we, of course, know that there's a deep need for behavioral health and access to behavioral health. I think the health system has done a great job over the last few years in improving our ability to service this community in a very meaningful way around behavioral health. I know that Scott Baker's got some information with regards to that.
Yeah, I'll just agree and touch on it really quickly that thanks to the hard work of our behavioral health team, we now have grant funding that is supporting even more space dedicated to behavioral health in all of our RHCs. So all of our RHCs now have dedicated integrated behavioral health space. The 3rd floor of the MOB is under construction. It will provide further space for the expansion of behavioral health. We're now doing developmental peds and neuropsychology. So a lot of growth in behavioral health, and I think 5% year over year is going to be our floor for growth, which is much needed in the community.
And this is a whole new service line within the last 3 to 4 years where we had no behavioral health. And I think our team is somewhere between 17 and 20 skilled individuals, probably doing in the 2,000 visit a year range right now. So it really shows a big commitment that's very, very rare in critical access hospitals for adults and now for children, as Scott just shared.
This is Director Barnett. Quick question. What type of patient does the neuropsychologist serve?
It's a mix. Your classic one will be obviously neurological based patients with long-term effects, concussions, some degenerative diseases will end up in that program as well. It's a pretty varied program, but the basic core is obviously neurological based long-term patients.
Great. Thank you.
Harry, a question. Some years ago, we had an outside vendor do an in-migration, out-migration study. Why wouldn't we seek to have them do that again for us versus us developing this ourselves? I'm just curious.
You're raising a great question. We've been using the CRINTS data or company data mining with our help too on Nevada and California, and it's a pretty deep database of where patients are going for care in our 3 dominant counties that we serve. And what we're looking to do is continue to do that in a consistent way, and it does show us the reasons why patients are going. But I think we're looking for even more nimble ways to track that, maybe more real time as technology continues to advance. Are there other tools or software that we could get that might be easier to assemble, have data that we can transform into management information even easier than the CRINTS data? So we do have a strong multi-year backdrop, but we're always looking to see if there's a better way. What's happening is in healthcare across the country, there's been a fairly robust inpatient array of data, and then the growth and understanding where outpatients travel and what their diagnoses were. That's been a frail area, much more frail for years, but it's growing in strength and quality. And so we're keenly watching that. And CRINTS did a lot of work and we're just continuing to see how that improves. Again, our health system has moved from our total revenues and volume was 67% outpatient in 2015. Last year was about 82%. This year it's about 85%. So we're kind of the flip where most big hospitals are 60 to 70% inpatient and the residual outpatient. We're 85% outpatient, which is more the prototype of future healthcare entities, that we're doing it in a way that saves money, probably $20 million a year for all payers and residents that experience it that way. But we're also dealing with the most fragile or incomplete area of database data mine on, and that's the outpatient array. But we do have good data. We're just trying to make it easier to get to and understand.
If I could just add, Director Chamblin, so the data that we do have is a couple of years old at this point. We've seen population growth. Clearly, it's likely something that we want to take a look at, and we may, in fact, use CRENTS again. There's no reason not to. But just imagine it this way, that's a snapshot in time that gives us exactly what has happened when the day we get the report, potentially what happened the previous year. There is software that we want to explore that actually it can move as claims data is being done, right? So we can actually see it, not necessarily real time, but you can see it and trend it out, and you can look at it by particular service lines. So if we wanted to see if maybe there was, this is not the case, but let's say our labor and delivery numbers were down, and we wanted to see, are they actually choosing another provider, or are we just not seeing as many deliveries in this particular month for what, various reasons.
Yeah.
So it's just an opportunity to look at it in a different way. But, that's part of this. We'll meet as a group and kind of discuss the best ways, and obviously keep in mind cost and try to figure out, where we can best meet the needs of this community with the data. And so the last slide was, in fact, questions and comments. I've kind of appreciated this. Has been a pretty good discussion all the way along. So I don't know if there's any additional questions or comments, but happy.
Louis, I do have one. If we can just go back to the prior slide, just so my memory's not so good to remember. So the far right column, help me out with definitions, because when I think of community and regional partnerships and I look at the metrics really seem to be more aligned with providing care and delivering outstanding experiences. It talks all about the care we're going to provide. Am I misunderstanding what if I think a community partnership, I would think establish a partnership with the school system to do X, Y, and Z.
Yeah. So
can you understand that?
Yeah, you're definitely onto something. So in terms of metrics, we're trying to find good ways to measure, how we are viewed in the community, how we're actually developing new service lines for the community and so forth. So it does fit. However, just in terms of the tactics, there are much more granular tactics that do speak to, setting up, programs where we can actually have students join us here at the health system and potentially look at healthcare as a future profession and how we would do that. And we can kind of look at how many students we would have each year, those kinds of things. All of the work around the JPA, so our housing authority, those are all the kinds of projects that do fit in this foster community and regional partnerships. And I would very much expect that these metrics will change as those programs develop a bit more, right? So it's kind of hard to measure the work on TTWHA or the housing authority until we have that measurement, like, are we going to secure a number of houses for staff in the community? Are we going to, put in a certain amount of dollars into the pot for the overall housing issue that the community has? Clearly we're supporting the work around the TARP, so the microtransit, And so these are things that we absolutely are working with the community. And I think we're going to see the metrics shift in year 2 of this plan and maybe a larger conversation in the board retreat. But I think we'll see it shift more into something we can measure with those regional partnerships.
And Director McGarry, just to add to that, some of these were there. They may seem on the surface exactly what you described, but behavioral health is a good example. We could never be everything to everybody in the behavioral health world. We just don't have the size system or the number of patients. So we do have great relationships with UC Davis and some partners in Renown in other areas in Reno. The telemedicine is another good example. We've already partnered with UC Davis to do some telemedicine on the inpatient world for neurology. So there are some community regional partnerships that will support those goals. Specific to those, I think that's part of the reason we put them in the column.
That's a great point. Thanks, Scott.
Louis, this is Ted. May I add a few things on partnerships?
Sure.
Kind of along the lines that Mr. Ward was going down, directors. For example, the Workforce Housing Agency, tomorrow we're going to be presenting to the Board of Supervisors in Nevada County with respect to that. They have an interest potentially of expanding that. We have developed relationships with veteran services at the county level and gotten them tied in with our behavioral health and mental health professionals here. There are benefits that are newly available to veterans that many of them do not know that are available to them. We are working with Nevada County to develop quarterly meetings on mental health and behavioral health. They've nailed down the quarterly dates. I've got to nail down the team and figure out how we can get calendars to sync up on that. We're going to duplicate that with Placer County as well. We also are members of and serve on the homelessness working group. We've been a financial supporter of the Warming Center. They've had a real challenge this year, 41 days open already this winter. And they're seeking some additional help, and we aim to support that. As Mr. Ward pointed out, we've supported the microtransit pilots both winter and summer. Council earlier this week, Town Council decided to extend another pilot for a year. We aim to support that as well, get vehicles off the road, and get people to use that microtransit program for their appointments on campus rather than drive and struggle with parking. In addition to that, on the governance side, we're developing new relationships with new elected officials. We've got a meeting coming up with Senator Krasner in state of Nevada, a new state senator. We've got a new state senator on the California side working on that as well, and a new congressional representative. And on the community health and population health side, we have a team working on the JEDI program internally, which is Justice, Diversity, Equity, and Inclusion. That team is going through a training program right now, which you'll hear more about later. They've done their second training this week. And those are just a few of those relationship types of things that Louis was talking about that are foundational and support the kinds of things that you see in the metric column.
All right, thanks, Ted.
One just additional thing on the workforce housing. The Workforce Housing Agency just approved a new strategic plan. And not only is it going to be working on the critical and very difficult housing needs of our 7 partners, but also it is focusing in on the small to large for-profit businesses that are really trying to survive in a region as well. And our organization recognizes that those companies are vital to having a well-established community or region that has some positive equilibrium or forward actions there too. So we have our just a long list of connections. We could talk for hours about the partnerships and connections.
Yeah. Louis, if I may, one more quick question, comment about in-migration, out-migration. A couple of years ago, Melissa came with the cancer department, said that somewhere around 50% of their cancer patients come from outside the area. Mm-hmm. I understand that Quincy is shutting, and of course with cancer, it's a very big money maker, and so bodes well for the hospital's finances. But I understand that the OB department in Quincy is shutting down. And OB, as I understand, is a perpetual loser financially. If these people are directed to us, are we going to try and shift them down to Reno, or how do we balance between giving customer service and yet maintaining a profitable business?
Sure. Well, thank you very much for that question. You know, it's very, very unfortunate, particularly with L&D or labor and delivery, that there are so many rural communities throughout the United States that just have very limited access to what should be, you know, something that should be readily available and, you know, within 15, 20 miles of everyone's house. And, but it's just really unfortunate the circumstances that have occurred over the last decade to 2 decades with regards to seeing that service line continue to leave rural communities. And yeah, it's due to cost in a lot of cases, but it's also due to competencies, right? So some of the rural communities, you might have 40, 50, 60 births a year, so roughly 1 a week, and it just doesn't allow for a fully competent staff when you're doing 24/7 care. So, you know, there could be a nurse on that team, that labor and delivery team, that may have delivered 1 baby in the last month, just based on the way that those babies came throughout the month. And so that lends to another problem that's not just cost related. So I am very, very proud of our labor and delivery department here. Not only is it an award-winning labor and delivery department, oftentimes one of our really crown jewels of the health system, but they're just extremely competent. And they, you know, this morning, many of us at 7 o'clock this morning met for an OB Peds meeting, and just the way that they go through cases and learn from each other and so forth is just really very, very unique in a critical access hospital, and particularly in a rural community. So when you see a Quincy close, I mean, it's sad for a number of reasons, but I'm just really happy that we're here and we can help them and help those patients try to deliver close to home. Unfortunately, you know, weather sometimes gets them to move towards the Chico communities and maybe even the Reno communities. But we are their choice. In most cases, those patients want to come here and deliver their baby here at the birthing center here. So we'll continue to keep doing that. We'll continue to always, as we do, we watch the finances. But I think in this case, you know, we're really not only watching the finances, but also being here for really what this hospital was, you know, born out of to
Yes.
get done, right?
Yes.
Like,
yes,
that was the mission of this hospital from day one, is to be here for labor and delivery. So we want to continue to keep that in body, mind, and spirit as we help our community partners. So
Louis,
any other?
just
Yeah, go ahead.
sorry to interrupt. Just to touch on that, Director Shamblin, you actually brought up a subject that hits everything in the right column. We've had recent conversations and met with Dr. Keppel and the leadership up in Quincy multiple times over the last few months since they've shut down. We actually have kind of an integrated program with our OBs and theirs. They're doing some of the basic care. They'll come down to ours for more of the advanced care, and then ultimately the deliveries, they're all lined up to come down to our hospital unless they need a higher level of care than we can provide, or if the weather doesn't allow them to come down here. In addition, we're talking about setting up a telemedicine program with them. So they have a clinician there meeting with our clinician and the patient together over telemedicine. So we're using telemedicine, regional partnerships, as well as just integrating those programs to the point where they've offered to pay us a consulting fee, and we politely said no. We're just being good neighbors. So a great point and a great topic. That's a great regional partnership for us.
Well, and one other point about that, Scott, if I can jump in on this. When you have an OP program that has relatively low volumes, that is at minimum staffing often, and has already an OBGYN on call and all the other expensive resources in position to do the OB care that you need to do, adding a small amount of incremental volume is not the negative hit that it might be if you have to build it. The problem you have is in these small rural communities, they have to have the staffing, they have to have their minimum staffing, and very expensive physicians on call all the time. And so for us, adding some volume is probably not the financial negative consequence that we would think about. I'm very familiar with trying to run a low volume OB unit. It's very difficult to do. So we can actually get some volume, probably a good thing.
Okay.
We're not, again,
Unfortunately, I envisioned that we were losing money on every delivery, but making up for it in volume. And that didn't seem to make sense. So.
Yeah, and it's not only the rural hospitals that are closing down because of their obstetricians not being available, et cetera. I mean, we just saw St. Mary's close down there.
Yeah, that's true.
And so it's, again, what we can do to help these is probably not that much of a financial burden because they may choose other places. I understand now that Sierra, I forgot the name of it now, the Nevada hospital that expanded, that they've opened their OB department to those patients as well. So again, they're going to have patients are going to have choices of where to go, and hopefully our reputation will bring them.
Yeah.
Right. With this, there's 600 rural hospitals that are in dire straits across America. And to me, I try to learn from every one of those. Our team does as well. Loyalton used to have a hospital. It does no more. Rural hospitals are disappearing in different areas, or service lines are going away, dropping of services, just as was shared. St. Mary's is dropping OB and peds. So the next 2 to 10 years will be very stressful for hospitals, big and small. And we're trying to navigate very carefully with a keen and caring eye for our community needs. And we've been really listening hard and acting and showing a lot of execution in the last 7 years, where we've taken about 75,000 round trips, not one-way trips, off the highways to Reno and Roseville, Sacramento, and the Bay Area, where people can get care within 1 to 20 miles just by trying to listen to our community's needs. And so we have patients that come probably from 5 counties and 2 states, which is really rare also in a rural setting.
All right, thank you.
Madam Chair, you may want to get some public comment at this point now that the presentation has concluded.
Do we have any comments from our board to begin with?
Yeah, this is Director Barnett. And I think maybe in our retreat we'll want to talk about this more. But one of the things that I see us doing, which I think is really positive, is that we're very community oriented, and we're really trying to identify the needs. And as Harry points out, we're going from what people think of as a hospital with inpatient care to a healthcare system where we're really identifying and trying to meet the needs of the community. And so we're less and less about patients in the hospital and more about identifying patients' needs and treating them in an outpatient setting. It seems to be the trend that our hospital is going. Perhaps that makes us somewhat unique among rural hospitals, but it seems to be a direction that is positive for all concerned. So that's my comment.
I think Harry has brought that up. So again, I agree with you, Director Barnett, that maybe we can do a little bit deeper dive in the retreat to find out more about the things that are happening with our strategic plan.
We are probably the second largest critical access hospital system in the nation right now, based on something I've seen recently.
That's remarkable.
Yeah. How about our audience? Do you have any comments or questions? Deirdre Henderson's got her hand up. And again, the rules apply, Deirdre. 3 minutes.
So I understand that CMS and the Joint Commission for Accreditation of Hospitals are looking into adding environmental sustainability to their judging parameters for hospitals. And I'm wondering if you have been following those developments and considering getting out ahead of them. I don't see anything about environmental sustainability in the strategic plan aspects that you've shown this evening.
If I could respond a little bit, the environment of care standards, there's hundreds or maybe even 1,000 of them that have to be precisely followed to be licensed in the state of California and nationally accredited. And we'll probably address that a little bit maybe next month, because there's a very precise list of criteria that's very different than any other business or any other residence or any other fire station or any other town building. And but we'll address that at a later date.
And as we've said before, Deirdre, we are preparing for national accreditation. So those kind of elements will be looked at and identified how we are meeting them. Any other comments from our audience? Okay, if not, that was just for discussion. And we can move on to, we had nothing pulled from our consent calendar. We can go to item 18, board committee reports. I think finance met.
Yes, Finance Committee, Mary Brown and I met last Tuesday, where we reviewed in some detail the Chandler investments, where questions were asked and answered by their representatives. We also reviewed the progress made in addressing accounts receivable. That seems to be a fairly consistent one that we take a look at every quarter. Mary and I hope you all noticed the December financials showed considerable improvement that brought our year-to-date much closer to budget. The DCL also showed that ER visits for the fiscal year-to-date reached a record high. Did any of you notice that in that little bar chart? That was pretty remarkable. I'd hate to think that this good snow that we get here is perhaps causing that record growth. Palisades Tahoe, formerly Squaw Valley, with all its great snow, has been incredibly busy, and I think Bob will confirm. The other day I left there at 4:00 after teaching my last lesson, and it took me an hour and 20 minutes to get 300 yards to Squaw Valley Road. It just seems to me, and Bob, maybe you'll confirm, it just seems to me that it seems much busier this year than it's been in the past. And of course, I assume that that's which could be partially driving our great increase in emergency room business.
And it's just not Palisades that is having such a volume of clients. It's also the traffic going to North Star has been unbelievably long and late, and the parking lots are full by 1:00 in the afternoon.
I feel captive. If I leave, I can't get back, so I can't leave.
Oh yeah. The Palisades Tahoe, their parking lot's filled by 9:00.
And again, it just increases the number that we will see in our emergency room because of the volume that we have here. Okay. Yep. Anything else, Dale?
No.
Okay. Any other committees that met?
Yeah, the foundation met earlier this month, and wanted to extend a public thank you to Harry for really addressing the concerns that the board had at the foundation. They're starting to get some feedback through the community, right? I think issues of access and other things that they felt was limiting or in some way affecting their ability to go out and fundraise and bring people in and get excitement about the hospital. And you go talk to a potential donor and like, hey, I tried to get an appointment. It took me 7 months. So Harry did a fantastic job sort of really putting, I think, the facts on the table for the board to review, and helped, I think, really provide a lot of direction and even potentially some input into sort of the strategic vision of the foundation, right? What's their purpose? What's their mission vision? How does it best support the health system moving forward? So it was a great conversation, and thank you, Harry, for listening to and responding to the concerns the board had.
Mary, you've got your hand up.
Oh, you're muted.
You're on mute and you got a hand. Oh, I got a hand. It's my hand that's up. Okay.
Talk, Alice.
I know. I'm really glad when this meeting is over. But going back to our committees, I hope all the directors got the list of who now serves on which of the boards committees. We sent that out so that you can start planning for your various meetings and have that on our calendar. So again, if you have not, to the board members, if you have not contacted your director, please do so and start scheduling and looking at your agenda. Again, this is your board committee, so you're driving what is going to be on your agenda. Okay. Are there any board member reports or closing remarks?
This is Director Barnett. I just want to comment on sustainability because Dale mentioned the traffic problem, and I know that on last Friday there was a fairly critical care patient trying to get from Palisades, Tahoe to the hospital. Took him 2 hours. And so somewhere in what we're looking at, I think we have to look at what seems to be kind of a changing environment around us. And I know there'll be a point where we get to that, but my comment is that we need to look around us and observe that and think about how it impacts the hospital and also what we can do about it.
Our workers getting to work and patients getting to healthcare. It's a big, big deal.
Yeah. Okay. So we'll keep that in mind, Director Barnett. We might be able to talk it further, or maybe Ted can help us look at, what kind of things we can support or partner with in order to get some of this information out, and how we can help with getting patients and people from point A to point B. I think we're trying that with the micro transit, but that's not going to be the only answer.
Well, you're right, Alice, and I just wanted to point out even the micro transit on the Placer County side can't get to Palisades any faster than anybody else.
No. Yeah.
So it's a big problem. We do need to talk to leaders at both North Star and Palisades after this season about these important.
Maybe we could have a monorail from the ski resorts.
Yeah, right. Elevated.
That was suggested about 20 years ago, actually. So.
Well, we may have to be rethinking in some of those directions, but I think as we go through part of our strategic planning process, it is something for us to think about, to see what what need to understand the problem better and start thinking about what solutions might be possible. And we may have to think bigger than what we're doing right now.
And also getting support. I mean, the town is the biggest entity that can do something, and we can partner with them if they need our information to go forward on maybe a different mode of transportation or something differently. But again, we're not the answer to everything. We can help. So, well, my last comment is that the board is going to go to the American Hospital Association Rural Leadership Conference in San Antonio in February. So we hope to bring back some information that we've gotten, networking, seeing what other board members are doing in terms of strategic governance, just some new ideas and some thoughts that we can share with them what we're doing and what they're doing, and bring it back and see what is it that's applicable here. So I'm looking forward to it. And like I said to our board members, the agenda is on the website. And so if you're interested in just seeing who's talking and what they're talking about, it's all laid out in your plenary and your concurrent sessions.
We can maybe do some camera shots of it or something, and Martina and I look at it or something and send it out to you so you can kind of see the whole agenda.
Okay.
Okay, Martina, you got another job to do. Okay. Any other comments? If not, the meeting's adjourned, and thank you so much.
Good night, everybody.
Bye.